Assalamu alaikum. Thank you for the introduction and thank you for the invitation. Where's the pointer? Hadira Khati. All right, so I guess I come in the right time to talk about my topic of the new oral antibiotics in pipeline after Hadil's presentation. So hopefully, Dr. Hadil, I'll give you more option to suggest next time. All right. All right, I have no disclosures. My objectives for the lecture is to talk about the impact of the increasing antimicrobial resistance, and I'll give you a brief overview about the recently approved antibiotics and an overview of the promising antibiotics candidates in the pipeline. All right, so the impact of antimicrobial resistance. So as we all know, that antimicrobial resistance has been affecting all countries with all income levels. It is responsible for 2.7 million global deaths in 2019 and has contributed to around 5 million of these deaths. The World Bank estimates that the AMR could result in up to 3.4 trillion US dollars losses per year by 2030. This is the recently posted or reported WHO updated their bacteria priority pathogen list. So you can see here that the Enterobacteriaceae, the CRO, and the Enterobacteriaceae ESBL has moved up, and our biggest enemy, Acinetobacter baumannii, was still in the critical group, and we still have the Mycobacterium rifampin resistant. Salmonella and Shigella has moved up due to their ciprofloxacin resistant, and from those who's interested, you could see the change from 2017 and 2024. This is a busy slide, but this is kind of sum up the problem. You can see the top 3 or 4 organisms that has high mortality, and it has low treatability options and low candidates in the pipeline, or they're unlikely to have a candidate in the pipeline. So I don't know about you, but this is exactly how I feel when they call me to discharge a patient who has an MDR bug. So let's see. Now we'll move on to talk about most recent approved antibiotics. So this is the WHO analysis report of the new medication. There was 12 new medication has been approved since July 2017. This is a table summary to summarize the most popular ones. There was 3 fluoroquinolones was approved. Only 1 was approved in the US FDA, which is delafloxacin. Dela has been very attractive because of its MRSA coverage. And it's indicated for skin and soft tissue infection and community-acquired pneumonia. I think the biggest issue with delafloxacin was the cost. It was very expensive, unfortunately. Omada is another good approved drug by the US, has been approved for CAP and skin and soft tissue and other indications. And then we have lefmulin is a new drug class also for CAP, and it has in vitro activity against MRSA and VRE. Pertonamide, we all know that that's been approved and joined the XDR treatment regimen for TB. And then the last one on the table, it's contizolid. It's actually similar in activity for linezolid, and it's approved in skin and soft tissue infection in China. And it has a better side effect profile than linezolid in having less bone marrow suppression. All right, so let me tickle your brains a bit. So you have a 40 years old female. She has a recurrent UTI, and she presented to your clinic with symptoms of cystitis. She has positive urine analysis, and you look at her previous urine culture and you see ESBL E. coli, and you look for the oral option. They're all resistant. So she doesn't want OPAD, she doesn't want to be admitted, and she wants only oral option. What would you give her? So hold the thought, and we'll see if you can come up with one or two regimen at the end of the presentation. All right, now we'll talk about the most promising candidate. So in the last WHO overview of the antimicrobial resistance that was released in 2021, 27 antibiotics agents targeting priority pathogen were reported. Only 14 of them were oral antibiotic candidates in the pipeline. So we always like to start with the beta-lactam. So let's see from those 14, what's new in the oral beta-lactam class. It has been a dream, and maybe that would interest you, Dr. Hadil, to have oral carbapenems option for the MDR organisms or the ESBL organisms. Sulpipenem is an oral carbapenem. It's a broad spectrum thiopenem beta-lactam antibiotics that has been studied with the combination of propenicid. So if you can see here, it has similar mechanism of action to carbapenem. It binds to penicillin binding protein through alkaline the serine residue and inhibiting the peptidoglycan cross-linking. It has been studied for both uncomplicated and complicated UTI, and also been reviewed for complicated intra-abdominal infections. The coverage of sulpipenem is similar to ertapenem, so it does not cover Pseudomonas, unfortunately. And the reason they use the propenicid with this drug is because propenicid inhibits the beta-lactam tubular secretion. So it leads to longer antibiotics half-life and higher serum concentration. Sulpipenem has been studied in two phase 3 trials looking at urinary tract infection and one trial looking at the intra-abdominal infection. In the urinary tract infection, they had SURE-1 trial and SURE-2. So they both are multi-centered, randomized, prospective, double-blinded, non-inferiority trials. In the SURE-1, they compared sulpipenem with propenicid, 500 milligram BID versus ciprofloxacin 250 BID. And they actually just included women in this trial who were 18 and above and had a confirmed diagnosis of cystitis. And the pathogen that were isolated, 14 of them were ESBL positive. It has very good outcome. The study had very good outcome in the urinary uncomplicated urinary tract infection, and it didn't show any major side effects or adverse effects beside the diarrhea and GI upset. So they call it, it was non-inferior for the Cipro for the uncomplicated urinary tract infection. In phase 3, when they looked at complicated urinary tract infection, they compared it with IV ertapenem. But unfortunately, the result for that study was not non-inferior to the ertapenem. So the FDA declared that it needs more data about the sulpipenem drug. We have another carbapenem, oral carbapenem called tipipenem. It has been designed or looked at for also urinary tract infection. It has similar activity to the sulpipenem. Tebipenem been studied in ADAPT PO, which they compared the IV ertapenem plus PO placebo versus IV placebo plus PO tepenem. And they included patients who had bacteremias. Um, the tepenem microbiological response was 59%, whereas in the ertapenem was 63.5%. The safety for that trial was nearly identical in the two group, with mild diarrhea and the um, GI upset. The FDA again were reluctant to approve this drug, and they asked for more data. This is just a summary for all what's out there for oral carbapenems. We have tebipenem that we talked about, and forapenem has been declined or not approved by the US FDA because they needed more data. And so far, our hope is the solpepenem. The tebipenem has been licensed in Japan and been used, and for forapenem been used in India. All right, let's move on to the next one. So the next one is a very interesting drug. It used a combination of ceftibuten and beta-lactam inhibitor, a new beta-lactam inhibitor called lidaborobactam. So this combination is currently under development to look for a multi-drug resistant enterobacteriaceae in the urinary tract. So what's special about this drug is it had coverage for almost all MDRs, including ESBL, KPC, and OXA48. And except for metallo, it does not cover it. And it has good bioavailability, and it's not a concentration dependent. So for me, it's still in phase 1 trial, but for me, this sounds very promising, inshallah. So this is just a summary for all the beta-lactams that are being looked at. Most of them were in phase 1. So is there any other classes? We all know the beta-lactams and the beta-lactam inhibitor combination. Yes, there is a new medication with a similar mechanism to fluoroquinolone, but had a distinct binding site. So it's called topomerase inhibitor 2. They have 3 antibiotics in this class. This interacts with a different site on the DNA diarase. And which is, you guys can see here where the binding site is so different than the fluoroquinolone site. They've been looking or looked up for uropathogenic E. coli, including the resistant to current antibiotics. So the first one of these topomerase inhibitors is giptodicin. Giptodicin has been looked at for uncomplicated UTI. They did 2 studies, Eagle 2 and Eagle 3. They're nearly identical studies, which is randomized, double-blinded, active controlling non-inferiority trial. They tried to look at the endpoint of achieving overall response and the test of cure visit at day 13. So giptodicin will be the new first in class of this this class, and this is how they randomize the study. So they randomize it by 1-to-1. The first arm received giptodicin with 1,500 milligram BID and a matching a macrobid or nitrofurantoin placebo for 5 days, and the other arm receiving 100 milligram BID of nitrofurantoin. and then they followed the patient up to 28 days. So you can see the pathogens in Eagle 2 and 3, the two trials. You can see that the ESBL positive were around 52%, and the fluoroquinolone resistant was also around 47% in the Eagle 2, and it was around 49.2 in Eagle 3. The study had really good results, and it actually ended early because of very positive results. So you can see that therapeutic success was 50.6% in Eagle 2 compared to 47% in Macrobid. And then for the Eagle 3 was 58% in gyptodicin versus 43% in the macrobid group. So they concluded that gyptodicin was non-inferior, and it actually declared as superior in Eagle 3. There were no major effects were reported. So to conclude my conclusion, this is a very good drug, it seems like, from the initial presentation. And honestly, I'm excited for its approval. So it's waiting. It has submitted for a new drug application, and it's waiting FDA approval. The last drug in this group was zolpidem. It has similar activity, but it has actually been looked at in resistant uncomplicated gonorrhea. And the third one, still, they did not disclose anything about it yet. It's still in recruiting. All right. So macrolides actually had a sit down for a while, and we haven't been using anything except for azithromycin. So they have been working on modifying macrolides. So we have the first generation, which was the erythromycin, and then we have the second generation with azithromycin. And then they worked on a third generation called telithromycin. Telithromycin did not have much luck with the FDA, and it was rejected early on because of hepatotoxicity. And then they started working on a new drug called solithromycin. So these ketolids has a different or more special mechanism than the first and second generation macrolides, which is bind to the 50 S ribosomal unit, and it has high affinity and selectivity to inhibit even the production of protein, and it can actually make it produce non-functional protein. So it's bactericidal, and it's their target or their function mechanism of action. Actually, they reported that it could overcome the macrolide resistant and bring back the macrolide monotherapy regimen. The first drug of these ketolides is solithromycin. It's a fourth generation macrolides. It's actually called fluoroketaloid. It developed for indication of CAP, and it has multiple coverage for macrolide resistant strep, enterococcus, and atypical organism. And it went through several studies, one phase 2 and 2 phase 3 trials called Solitaire. One compared just to an oral regimen of the solithromycin versus the moxifloxacin. And the other study actually compared, they started with the IV solithromycin and IV moxifloxacin, and then they switched to oral of each form. So they concluded the both studies actually solithromycin was non-inferior to the moxifloxacin in treatment of CAP. It did had some problems with the study. FDA did not approve when it was submitted for new drug application because they found that a lot of the side effects has been associated with hepatotoxicity. So they found that liver enzymes or ALT elevation was more in the silithromycin group. So they put it on hold and they requested for more data, and they actually asked for more than 9,000 participants in the trial to consider approval. All right. The other one was nephromycin. It's another lactone ketolide, also being studied for CAP. It has completed phase 1 and phase 2 so far, and they actually compared it to oral moxie. Uh, the the good thing about this is a short course of 3 days, and they have initially found that the safety profile for nephromycin is better than the solithromycin and telithromycin because the ring in it, the function of the mechanism of action does not produce or accumulate and cause the liver injury that's been seen with the other ketolides. All right, this is just a summary for you guys where they are. So telithromycin withdrew from the market. Another one called cithromycin has been proposed but stopped, never seen market because of the toxicity. Solithromycin has a concern of hepatotoxicity, so they required more data. Nephromycin, we're still waiting for the FDA approval. So I'm almost done. So these are other candidates on the horizon. So uh, keep an eye for it. So you have several options for CRE and one for Acinetobacter baumannii. And this is just a summary for each. All right, so to take home message, AMR remains the top global public health threats facing humanity. There is no viable market for the novel antibiotics due to their low return and which fails to recover or cover the cost of their development and manufacture. There is new exciting new beta-lactam with beta-lactam inhibitors for MDR's urinary tract infection, and maybe in the future for bacteremias a step down. And there's a new topoisomerase 2 inhibitors that's also been showing great promise. Stay alert of the new medication resistance or new mechanism of resistance. And I'm pretty sure these things will be costly, but inshallah, we'll see. Any questions?